Welcome back to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon for over 25 years. Today, we're going to be doing something a little bit different, thus the casual attire and the lack of the white coat. Instead of talking about a more clinical or didactic type of neurosurgery topic, like brain tumors or spinal herniated discs, we're going to be talking about a topic that unfortunately will always be something a neurosurgeon is expected to be able to do, and that is telling a patient or their family members bad news. As the title suggests, these are conversations where you're going to be telling someone that they don't have much more time on this earth, or that their family member is not going to wake up after this car accident. Death, unfortunately, is part of life, and sometimes I have to tell someone it's going to be coming early. Also, unfortunately, this is something we're not really trained how to do very well. Combined with the personality traits that are often required to become a neurosurgeon in the first place, this ends up leading to the general consensus that neurosurgeons are not particularly good at having these conversations. I've always been told I have a relatively good bedside manner, and when I was a resident, which seems like a very, very long time ago, I was always the one that got sent in to talk to the families about bad news. So in addition to this video being for patients and family members that might be curious about what goes on in the mind of a neurosurgeon that's trying to have a conversation like this, this video is also for neurosurgeons, or more importantly, neurosurgeons in training, that hopefully can take some of what's said in this video and use it to help their patients get through probably what is one of the most difficult times in their lives. So let's get to it. How do you tell a patient or their family member that they don't have long to live? So there are few moments in medicine more difficult than when a neurosurgeon has to sit down with a patient or their family and say, "You may not survive this," or "Your loved one may not survive this." These conversations happen after devastating strokes, traumatic brain injuries from motor vehicle accidents or falls, spinal cord injuries, ruptured brain aneurysms, brain tumors, infections, anything that can cause severe swelling of the brain. And for patients and families, the experience can feel overwhelming, unreal, frightening, emotionally disorienting. For neurosurgeons and intensive care teams, these discussions are deeply difficult. They involve the balancing act between honesty and compassion, uncertainty and clarity, medical facts and human emotion. So in this video, we're going to talk about why neurosurgeons sometimes have to have these conversations, how doctors estimate prognosis, which basically means the chance of survival or recovery, and why uncertainty can be so common in neurosurgery patients in particular, what's normal for patients and their families to experience emotionally, as well as some common questions that families might ask, discussions about end-of-life decision-making, and then a little bit about being hopeful but at the same time realistic. Navigating this kind of time in their life is going to be one of the most difficult things that a family can do. So things a neurosurgeon can do to say and help make these conversations a better experience for both them and their patients are what we're going to be talking about the most. So let's talk a little bit about why these conversations about life and death are more common in neurosurgery. Well, the primary reason is that neurosurgery deals with some of the most delicate and vital structures in the human body. And these are things like the brain, the spinal cord, major blood vessels, the nerves that control movement, speech, breathing, memory, personality, and consciousness. Sometimes these neurological injuries are survivable, sometimes they're not, and they're catastrophic. Sometimes doctors genuinely do not know initially whether a patient is going to recover or not. And although not a complete list, some of the common situations where these conversations may end up occurring include things like severe traumatic brain injury. This can occur after motor vehicle accidents, and that includes things like cars, motorcycles, ATVs, snowmobiles, etc., after falls, after assaults, sports injuries, gunshot wounds. In addition to the initial effects of the trauma, the brain may later swell or bleed and suffer more widespread damage. And if this is the situation that's going on with your situation or your family, you can also take a look at one of my other videos entitled, "Someone I Care About is in the ICU with a Traumatic Brain Injury. What Should I Think About?" And that's on the YouTube channel. Please go ahead and look at that. Another common situation that can lead to this conversation are large strokes. This can destroy critical brain tissue that can be responsible for consciousness, language, movement, swallowing, breathing, things like that. Another devastating one is a ruptured brain aneurysm. This can cause sudden bleeding around the brain called a subarachnoid hemorrhage. Patients can rapidly deteriorate into a coma or death. And only about 50% of patients with ruptured aneurysms survive long enough to even make it to the hospital. And of those that make it to the hospital, only about 50% of those make it out of the hospital. Brain tumors are another neurosurgical problem that can lead to these conversations. Some brain tumors are aggressive. Some of them can be in locations that can't be safely operated on, or they're discovered very late. Other brain tumors can cause severe swelling or pressure on the brain. Overall, though, it's relatively rare that a patient's life is going to be at risk in the short term after being diagnosed with a brain tumor. Typically, brain tumors will cause problems that lead to their diagnosis months or even years before actually causing death. A side note here is that brain tumors are actually relatively rare in the sense that neurosurgeons might have to have a conversation about prognosis or how much time a patient has left. And that's because physicians that usually have that conversation with patients and their families are usually the oncologists or the radiation oncologists. Neurosurgeons are often involved with these patients during the surgical process where the brain tumor is either removed or biopsied. And usually during this time period, the final pathological result of the tumor, which in turn is going to determine the prognosis, isn't really known. So the neurosurgeon might know the preliminary results of what the tumor is because of a sample taken during the surgery, but that's not really the final or most accurate result. In addition, a lot of answers about prognosis are going to depend on molecular studies on the tumor tissue itself, which usually isn't known for a week or two after the surgery. So as the neurosurgeon, you might be asked soon after the surgery, how bad is it, doc? And you may end up talking about the preliminary pathology results, which may have shown that the tumor was either malignant or benign. But when it comes to actually talking about how much time that patient has left, as a neurosurgeon, it's relatively rare that you're going to have to give them that answer. You won't be able to give them a truthful, honest, accurate answer to that question immediately after the surgery. So oftentimes the actual conversation is going to be with another type of physician like an oncologist or a neuro-oncologist and not the neurosurgeon. So other injuries that neurosurgeons deal with that can lead to these conversations include some severe spinal cord injuries, especially spinal cord injuries that are high up in the neck. These can impair breathing and can lead to all sorts of life-threatening complications. Brain hemorrhages for any reason and brain infections from meningitis or encephalitis can progress rapidly and lead to severe swelling and eventually death, and this is despite all the heroic and medical and surgical efforts. When these types of problems occur, neurosurgeons have to evaluate not only whether the patient can survive, but also what kind of recovery is possible, whether surgery is going to help or not, whether putting the patient through surgery could prolong their suffering but not provide any meaningful recovery, whether an injury is reversible, and finally, how to factor in the patient's own wishes if they are known. These can be some of the most emotionally, clinically, and ethically complex decisions in medicine. So families will often wonder, how does the neurosurgeon really know how serious this problem is, or the likelihood that the patient's even going to survive? What kind of things is the neurosurgeon thinking about? Well, the answer to that question is that neurosurgeons combine many different pieces of information together. No single piece of information can really tell the whole story. The neurological examination is one of the most important tools the neurosurgeon has in determining the prognosis of a patient. If a patient's neurological exam, which includes things like their level of consciousness, their ability to follow commands, eye-opening, the responses of their pupils to light, breathing patterns, movement in the arms and legs, reflexes, responses to pain. A patient who can speak and follow commands generally has a very different prognosis from a patient who has no meaningful neurological responses. Especially in trauma patients, the neurological exam in the beginning is the biggest indicator of the patient's potential for survival and the degree of functional recovery that they're going to have. Imaging studies such as CAT scans and MRIs are also very valuable in helping a doctor figure out how bad things are. These will show things like bleeding, swelling, brain compression, brain herniation, which is the degree that the brain is being pushed through certain spots in the skull, the size and location of a stroke or a bleed. If there's a tumor, what kind of characteristics do the tumor have? If there's spinal cord damage, what kind of damage to the spinal cord is there? Keep in mind that sometimes imaging can look terrible, but the patient clinically might not look too bad. Other times, the scans may look only moderately abnormal, but the patient's in terrible shape. Intracranial pressure is one of the most common things that can lead to tough conversations about survivability in neurosurgery. And that's talking about basically brain swelling with traumatic brain injury. In severe brain injury, the pressure inside the skull can rise dangerously. And because the skull is sort of like a closed box, the swelling has nowhere to go. This swelling will often gradually increase over the first 3 to 4 days after an injury and then decrease. And high intracranial pressure can then become greater than blood pressure, and then blood flow to the brain can be reduced, which can lead to further injury and further swelling. Interestingly, younger, healthier patients that you would expect to do better medically actually tolerate brain swelling much less than older, more frail patients because of something called brain atrophy. As we get older, our brains shrink, but our skulls stay the same size, and this means that older people with atrophy have more room in their skulls to accommodate brain swelling. Anyway, this is why when I have conversations with head trauma patients and their families, I tell them that the first 3 or 4 days is the most important in determining not only if the patient's even going to survive, but what kind of shape they might be in if they do make it. So I usually will explain that the kind of shape the patient's in neurologically in the beginning, it might be good, but the next 3 or 4 days I'm expecting brain swelling, which could cause problems. The critical care team and myself are going to do everything in our power to combat that brain swelling, and as a last resort, that may even include surgery to relieve the swelling or create room for the swelling. And that ultimately, if the patient can survive the initial injury and the subsequent swelling, that how they end up neurologically is most dependent on how they looked initially. I really don't say this out loud to families, but ultimately, I've always preferred to paint a relatively pessimistic picture and have the patient or their family be pleasantly surprised, then paint them a rose garden and have them be disappointed. So, after 3 or 4 days in the ICU, if a patient with a severe head injury is not improving, or if they're deteriorating, I'll usually sit down with the patient's family and begin the process of having conversations about prognosis and the possibility that the patient might not survive. Other factors that influence outcome in these patients is the patient's age and their baseline health. Younger, healthy patients may recover from injuries that would not be survivable in an older, medically fragile patient. These are things like heart disease, lung disease, kidney failure, how frail the patient is, dementia, and then of course their baseline neurological function. So now let's talk about one of the primary things that makes conversations about patients with severe neurological problems so difficult for both the neurosurgeon and the patient or their family member. One of the most difficult realities for both the neurosurgeon and the patients or their families when it comes to a neurological injury is uncertainty. Unlike many medical conditions where outcomes can be predictable, neurological injuries that involve neurosurgeons can often evolve over hours, days, or even weeks, leading to constantly changing reports about how the patient is doing. Families, understandably, want certainty. And they might ask things like, is he going to survive? Will she wake up? Will he walk again? Will she ever be herself again? Those kinds of things. Unfortunately, medicine often cannot provide precise answers, especially when it comes to the brain. The brain is extremely complex, and it contains billions of interconnected nerves, Add into this that every individual is different. Even modern imaging can't predict perfectly how much function may recover after a brain injury. And remember, injury to the brain may not always be immediate and complete. There may be secondary injury which can develop later. This can be due to things like swelling, lack of oxygen, seizures, inflammation, low blood pressure, and infection. Occasionally, patients recover far better than expected. Other times they do poorly, despite looking pretty good in the beginning. So this uncertainty is emotionally very difficult for not only for the neurosurgeon, but the patient and their families. Navigating how to effectively communicate these ups and downs and these uncertainties definitely takes some skill. Unfortunately, not much of this skill comes from actual training. I think a lot of it comes from practice, and some of it comes from innate personality. Families can often feel frustrated when the doctor can't provide exact predictions, but as the neurosurgeon, it's important to explain to patients and their families that uncertainty is not the same as dishonesty. Most neurosurgeons understand that these conversations are life-changing moments for families, and whenever possible, we should try to do things like speak in a private setting, trying to minimize interruptions, use understandable language, avoid excessive medical jargon, allow time for questions, and include other members of the care team like the intensivists, the pulmonologists, the infectious disease specialists, those kinds of people. We should also try to avoid vague language that could create misunderstanding. For example, instead of saying something relatively general like, things aren't really looking good, you might instead want to say something like, this injury is severe enough that John or Joe or Jane could die from this. Or even if he survives, meaningful neurological recovery may not be or is not going to be possible. Remember, clear, truthful communication, no matter how bad the news might be, is going to help families make informed decisions. And I found that almost all families and patients are going to understand this, even if the news is terrible. Experienced neurosurgeons will often speak in probabilities rather than guarantees. And in these cases, I'll often say things like, the chances of meaningful recovery are very low, or we're cautiously hopeful, or Joe or Jane are showing some encouraging signs, but there are still many risks and hurdles that have to be overcome. Or something like, we may need some more time before we can truly have a better idea about the likely outcome. Something I'll almost always say, probably towards the end of the conversation, is I encourage everyone to be hopeful, but at the same time, be realistic. All these phrases are not mere platitudes. I'll usually be sitting down at eye level with a family member. Sometimes I'll even be holding their hand with both of my hands. And when you say these things with genuine empathy, while you're looking someone directly in the eye and at the same time expressing certainty and confidence, you're going to be doing a great service to that family. Remember, they're looking first for honesty and second for compassion. Also remember that families under this kind of stress often can't really absorb everything you're telling them during one conversation. It's extremely common, and people may realize that they forgot large portions of what you just told them. Also remember, these families are grieving. The first stage of grief is denial, and a family member simply may not be able to psychologically accept what you're telling them, the first time at least. It may take a few days of repetition, a few days for them to reflect on what's going on, for them to really kind of come around to the situation. That's why discussions that repeat what have already been said are often necessary and should not be thought of as a waste of your time. Families should never feel embarrassed about asking neurosurgeons questions, and neurosurgeons should be prepared to answer questions like, can you explain that again? Or what does that exactly mean? Or things like, what are you most worried about? Or what outcome do you think is going to be the most likely? Being able to answer these questions honestly and with confidence and with a sense of compassion, that can go a long way in helping a family get through probably one of the worst and most challenging times in their lives. So now let's talk about the emotional responses that families will often experience when they're faced with this kind of situation. Remember, there's no real, correct or right emotional response to getting devastating news like this. People react differently. Some common reactions include things like shock, where families might describe feeling numb or disconnected, or that everything you're telling them isn't real. Sometimes they experience denial, where they might say something like, there has to be some kind of mistake, or that's not true. This can be totally normal psychological response to overwhelming stress. Anger is something that's relatively rare, and this can be directed towards the medical system in general, the injury that happened to the patient, other family members, the patient themselves, or other members of the healthcare team. I've seen this happen on TV, but I've never had a family member or a patient get angry enough to verbally or physically lash out at me after they've been given bad news. I just haven't seen that. Guilt often sneaks its way into the minds of patients and their family members. They may replay events over and over in their minds. They may wonder or repeatedly ask things like, could we have prevented this? Should we have come to the hospital sooner? Did I miss warning signs? Guilt will also come into play when you're asking patients' family members to make medical decisions in a setting where the outcome may not yet be known, which is very common with neurosurgery patients. For example, I'll often sit down with patients' family members. I'll explain to them that if I operate now, I might be able to save the patient's life, but there's a chance that they might still be neurologically devastated after the surgery and will never be able to take care of themselves. I'll then go on to explain to them that it's totally normal for them to feel guilty in either case, whatever they decide. If they decide to let me operate and the patient does not survive, they might feel guilty that they allowed them to go through a surgery for no reason. If we operate and they survive but they're neurologically devastated, they might feel guilty that they prolonged their life with such a terrible prognosis. So preparing a patient's family members up front with this reality about guilt will often give them much better tools to deal with the actual decision-making process. Also keep in mind you might see a lot of conflict within a patient's family. Different family members may interpret what you're telling them differently. One person may want maximal treatment, very aggressive treatment. Another might believe that the patient would not want prolonged or aggressive life support and they want you to just leave them alone. These disagreements can become emotionally intense. And what I will often say is that any help or information I can give you to help you make this decision, don't hesitate to let me know. I will give it, but just let me know. In addition, I'll fairly be frequently asked, something like, what would you do if this were your mother type of question. In these cases, I'll simply tell them the truth and remind them that my answer is partially based on me personally and may not be relevant to their particular case or their particular background or history or relationships. So now let's talk about some typical questions families might ask during these situations. A common one is my loved one suffering? I'll remind them that this depends on the patient's condition and their level of consciousness, and that patients in a coma likely have limited awareness. At the same time, I'll be honest, if the patient is likely experiencing pain or agitation or discomfort, I'll remind them that both myself and the ICU teams are very good at and work aggressively towards managing things like pain or anxiety, or seeing things like shortness of breath or agitation. Comfort is a major priority, but sometimes I'll remind them that we have to sacrifice comfort in order for us to monitor the neurological exam. Another one I hear is, can they hear us? Sometimes patients with impaired consciousness may still process voices or familiar sounds. So because of this possibility, I'll often encourage families to speak to their loved one calmly and supportively. Another one I hear is, what would their recovery look like? And I almost always tell them that recovery is kind of on a spectrum. Some patients return to nearly their baseline. Others might survive with potentially devastating deficits. For example, things like paralysis, problems with memory, concentration, or attention, speech difficulties, depending on feeding tubes, the need for long-term nursing care, and then even the possibility of a persistent vegetative state where they're really not conscious. I'll also mention my belief that recovery after a neurological injury usually occurs in 2 phases. The first is typically in the first 30 days, and this comes from the recovery of parts of the brain that were upset but not permanently damaged. And then there's the second phase, which takes place over a much longer period of time, even up to a year, where the brain actually reorganizes to compensate for the parts that were permanently damaged. And I'll almost always tell the patient or their family that in about a year, you can look in the mirror and what you see is probably what you're going to be stuck with. Another question I'm often asked is, how long until we know what's going to happen? And I'll usually answer that this can vary tremendously. Some outcomes become clear within hours of the injury. Others can take days or weeks of observation. Sometimes I'll be asked, should we continue aggressive treatment? And that's one of the hardest questions I come across because it can become very difficult to keep my own personal ideas or opinions out of the answer. The answer depends on multiple variables, some of which I personally have nothing to do with. Things like my personal beliefs about the value of life, about ethics, have nothing to do with the medical facts of the situation. Those answers depend on things like what are the likelihood that the patient's going to recover and the quality of life that they're going to have, what are the patient's values, religious, cultural beliefs, prior expressed wishes. Many families think that they're giving up if they choose comfort-focused medicine or care, but choosing comfort care is not the same as abandoning a patient. Sometimes continuing invasive or aggressive treatment may actually prolong a patient's suffering in the case of someone who might not have a realistic hope of recovery. Other times, aggressive treatment might be totally appropriate and necessary, but every case is different, and what and how you say what you say to patients and their families is going to influence those important decisions that they have to make. This is a tremendous responsibility. Unfortunately, some neurosurgeons don't realize that that responsibility should get the same attention and the same dedication that they give to preparing or performing their surgeries. So, it should also be understood that patients with a severe neurological injury may require life support measures, and these are things like mechanical ventilation, feeding tubes, medication drips to maintain blood pressure, brain pressure monitoring, which might require a tube to be implanted in the brain tissue, repeat surgeries. All these interventions can be very, very stressful, not only for the patient but their families. And sometimes the medical team has to talk about serious topics for things like do not resuscitate orders, whether to withdraw life support, arranging hospice care, and whether to decide on comfort-based care. These decisions are very difficult to make. The discussions are difficult to have. I'm not going to go into the specifics of each of these particular interventions or care decisions in this video, but just keep in mind that these discussions again require both honesty and facts, but at the same time, compassion and empathy from the neurosurgeon. In situations where a patient can't speak for themselves, it can be helpful to suggest something called substituted judgment. This basically means suggesting to family members that they try to imagine what would the patient want if they could speak for themselves. This can be very painful emotionally to the families, but it'll help center their decisions around the patient's values rather than their own fears or anxieties. So if it looks like a neurosurgery patient, although severely injured or ill, is still going to survive, it's a good idea at some point to remind the family that not every devastating neurological injury results in death. Some patients can make remarkable recoveries. Others recover only partially, but they're still able to find a meaningful quality of life. Almost all of these patients end up requiring some form of neurorehabilitation. This includes things like physical therapy, occupational therapy, speech therapy, cognitive rehab, psychological rehab, psychosocial support. Recovery can continue for months or even years, and families should be encouraged to learn to celebrate even small milestones like a patient opening their eyes or following commands, speaking a word, moving a finger or toe to command, taking steps, eating independently. All these things are wonderful and are prognostically good, but at the same time, the families should be reminded that realistic expectations are also very important. Recovery from severe neurological injury can often be slow and can often be incomplete. There can be permanent disabilities where a patient may not be able to do many of the things they could do prior to their injury. But it should be emphasized that hope and realism can coexist at the same time. When a neurosurgeon tells a patient or a family member that a loved one might die, it's one of the most serious conversations in medicine. And it's difficult for the patient and their family, and can be also very difficult for the neurosurgeon. These moments involve medicine, ethics, uncertainty, emotion, grief, and humanity all at once. For families, the experience is often overwhelming. For healthcare professionals, these discussions are fraught with the challenge of being honest, but at the same time compassionate. For the neurosurgeon, there are a few suggestions that I think might help you maybe get it right. The first is time and practice. These will, of course, make you better at it. Try to use some of the expressions and phrases I mentioned earlier in this video and tweak them to the specific situation you're dealing with, as well as your own preferences. This also means, especially during training, don't pass up the opportunity to take on the challenge of having these conversations with patients and their families. Even if you're just a resident, even if it feels scary, and even if you're worried you're going to do a bad job. Don't forget, a bad job done today will help you do a less bad job tomorrow with somebody else. That's how we get better at things. Another thing you can do to help consistently do a good job with these conversations is to remind yourself that the responsibility of doing that conversation the right way is just as important as doing the surgery the right way. The patient and their families are counting on you to be good at what you do in all aspects of your job. Sit down in the chair next to them, look at them in the eye, hold their hands, let them deny, let them be angry, let them ask you to repeat everything you said the day before. To you, it's just another day on the job. To them, it's the worst day of their life. As neurosurgeons, you were born with the ability and trained to always put in 110%. There's no reason this can't be done when you're telling someone they only have 6 months to live. Thank you again for watching the Your Go-To Doc YouTube channel. I know this was not the usual clinical video I usually make, but I hope it was still worthwhile. I hope it was useful for neurosurgeons hoping to help their patients and their families. And I hope it was useful for patients that might be curious, what's going through the mind of doctors when they have to have these conversations. If you found this video helpful, please consider subscribing to my YouTube channel, as well as sharing it and giving it a big thumbs up. And most important, don't forget the most important thing: stay healthy.